Are you aware of Warty lesions? What is a wart? Any growth with finger-like projections above the skin surface or mucosal surface are called warts. Not all Warty lesions are cancerous. Often the warts are non-cancerous, but some Warty-like lesions need to get a final diagnosis. Only histopathology will tell whether it's cancerous or non-cancerous. Here is a case with Warty lesion.
42-year-old male presented with itchy papillonodule over right forefoot since 6 months, and it was associated with false smelling intermittent discharge. And look at this, there is on the dorsum of forefoot, you can see exophytic growth. It has got papillary projections. It looks like a wart and measuring around 1 by 1 centimeter. And look at the edges, which are almost undermined edges with surrounding skin is hypopigmented. Some of these areas are showing crusting, and the excised specimen came for histopathological examination. And look at the whole lesion. There is increase in thickness of this epithelial or epidermis, and there is a papilla formation. There's another papilla, another wide papilla, and look at this hyperkeratosis. And interestingly, uh, the middle epidermal layer, starting from stratum malpighi to the stratum granulosum, it is somewhat showing disturbed keratosis. We call it as dyskeratosis. And the lower epidermal layer almost uh, showing regular keratinization. And look at the suprabasal zone. You can see small clefts, and here also. It's mainly it is due to acantholysis. So here, this whole lesion, it looks like a crater, and it is lined by hyperplastic stratified squamous epithelium. And this crater is whole thing is filled with dyskeratotic material, and there is suprabasal acantholytic clefts of varying sizes. And dermis, of course, it is showing inflammatories and infiltrate. And higher magnification of the same thing, you can see the dyskeratotic material, and it is of course suffused with basophilic structures, and they are nothing but, we'll see later. Yes, these are actually showing dyskeratotic cells. You can see the precipitated keratin material and the apoptotic nucleus, a pycnotic nucleus. The whole thing is, again, there is a perinuclear halo, and they are called actually corpse ronds. And here also one more corpse rond. Many of these things are all corpse ronds, and some of the epithelial cells are flattened with flattened nuclei in this, particularly in the stratum corneum. They are called corpse grains. So this is a form of dyskeratosis. Normally what happens, the keratinization is a graduation process. It starts with acquisition of uh, less number of keratohyalin granules in the stratum malpighi, and those things are pronounced in the higher up, particularly is rich in stratum granulosum. And of course this keratin material is uniformly distributed to provide pink appearance in the stratum corneum, but at that time the nucleus gets extruded to become stratum corneum. So this all graduated keratinization process is disturbed here. So disturbed keratosis, we call it as dyskeratosis. And of course there are many stimuli for this dyskeratotic process, including infectious etiology. Maybe sometimes it is also seen in case of neoplastic condition. So this is very important. But nucleus is typically very bland in appearance, doesn't show any uh, pleomorphism as such, except for dyskeratotic features without much nuclear pleomorphism. So carbs grains and carbs rods uh, that is very prominent in this cup-shaped crater like lesion. Coming to the basal layer, this is almost it is showing regular keratinization. Only thing it is interrupted with the suprabasal intraepidermal clefts of irregular shape, irregular size, but their number is less, and they are also filled with acantholytic cells. And the inner spaces are very irregular. They are showing villus-like structure, and of course, and you can see the dermis is showing mixed inflammatory cell infiltration. No much evidence of vasculitis here. One vessel is seen, no significant vasculitic feature. Yes, higher magnification of the same thing. Acantholytic cleft here, varying sized acantholytic clefts. Acantholytic cell is there here, mixed inflammatory cells. You can see nice micro villus projections here in these clefts. So what are the histologic findings in this case? So most important thing is there is acanthosis, increase in the thickness of the epidermis, and of course it is suffused with papilla formation lined by hypoplastic stratified squamous epithelium, hyperkeratosis. Most important thing is the middle layer. It typically it shows cupuliform, that is crater formation is a characteristic lesion of this characteristic feature of this lesion, and is filled with dyskeratotic material. So crater with dyskeratotic material and intraepidermal clefts with acantholytic cells present within this. So these two features. So I would like to call this as acantholytic dyskeratosis. This lesion. So what are the lesions you come across acantholytic dyskeratosis? So most important thing is the Warty dyskeratoma. Here the lesion is very solitary, and uh, the acantholytic clefts are less in number, and there is a typical crater formation filled with dyskeratosis. Grover's disease, again, it is a form of Warty only thing, the Grover's disease is multiple in lesion, multiple in number, and of course, to begin with, the acantholytic clefts are less in number, so it's also called as transient acantholytic dermatopathy or dermatosis, and to at the later stage, they also show well-formed Warty Darius white disease and Haley disease, kind of a combination of papillosquamous disorder plus associated with significant number of bullae formation, or you can say vesicle formation, particularly in the suprabasal zone. Clinically, both the lesions they show multiple lesions. Multiple lesion is a feature, whereas in contrast, Warty keratoma is a single solitary lesion. So here Darius, this is the typically acantholytic clefts are there, but in contrast to Warty keratoma, the crater is typically absent. Only the dyskeratosis is seen very focal, whereas Haley disease, acantholytic clefts are there, hyperkeratosis is there, but there is absence of dyskeratosis. That's how it differs from dyskeratoma. Keratoacanthoma, as the word itself indicates, acanthoma means acanthosis, increased thickness is there, but clinically it presents like papilloma or Warty-like growth. But typically there is a lack of acantholysis in the acantholytic cleft, and there's a focal areas of dyskeratosis may be observed in keratoacanthoma. And next thing is verruca vulgaris, of course, is a true wart, and there is a lack of crater formation, and dyskeratosis is not a feature here in verruca vulgaris. And of course, this lesion is typically associated with human papilloma virus, and of course, cytologic changes such as chyliocytotic change is a typical finding in this lesion. So that's how it differs from Warty dyskeratoma, which is typically not associated with human papilloma virus. Molluscum contagiosum, of course, it is also a cup-shaped lesion, papilloma-like lesion, Though leg is or foot is unusual site, usual sites or head and neck region, here the lesion is typically there is a disc keratosis. It occupies the whole of the thickness of the epidermis, starting from basal layer to the stratum granulosum and stratum corneum. And here, typically, this molluscum bodies, they are nothing but viral particles plus precipitated keratin material. So, they are corpse ronds. They are very typically seen in case of molluscum contagiosum, though the site is not a common. And lesions are multiple in case of molluscum contagiosum, in contrast to a solitary lesion of Warty disc keratoma. And look at this pictorial depiction of the lesion. Here, Warty disc keratoma, typically the crater formation is there filled with diskeratotic material in the form of corpse rods, and number of clefts, acantholytic clefts are less here, but acantholytic clefts are more pronounced with typical villus formation in case of Darier's white disease. And of course, the dyskeratotic feature is very focal here and there in a hyperkeratotic lesion, whereas Haley disease, there is typically the dyskeratosis is absent, and other features are similar to Darier's white disease. And vasculitis is a typical finding in both Darius white and Haley disease. And look at the molluscum contagiosum, the dyskeratosis in the form of corpse ronds, and its molluscum bodies. Typically, it occupies whole thickness of the epidermis, starting from basal layer to the stratum granulosum. And hyperkeratosis is a typical finding in all these cases. And this is the table uh, which highlights the salient features. Varicose keratoma, usually it is a single lesion, whereas all other conditions are multiple. And verruca vulgaris again can be solitary or multiple. Darius white and Haley, usually the papillus squamous, sometimes bullous also. And intraepidermal crater is a characteristic feature seen only in case of Warty disc keratoma and sometimes observed in case of molluscum contagiosum. Whereas acantholysis is a prominent feature in Darius and Haley, whereas it is present in Warty disc keratoma and Grover's disease, though the numbers are less. And the villus formation is not a typical feature in these two conditions. Dyskeratosis, very prominent feature of Warty disc keratoma and molluscum contagiosum, and of course it is not much pronounced, but it is present focally in case of Darier's white disease. Yes, I would like to label this as Warty disc keratoma. It's a benign follicular neoplasm and of unknown etiology. Definitely, it is not associated with HPV as the Verruca vulgaris is associated. It is not associated with that. And definitely, it is a distinctive clinicopathological entity nowhere related to Darier's disease and more common in head and neck region, but can occur in other mucosal sites, including oral mucosa and other extremities. Adult male is commonly affected, and often one can find acquired genetic mutations involving sarcoplasmic and endoplasmic reticulum, calcium protein, calcium pump, channel pump protein that is mutated. That's very important protein which maintains the intercellular adhesion that is responsible for lack of intercellular adhesion, and of course there is acantholysis, and that stimulates the proliferation of epidermal cells in a haphazard manner or dyskeratotic manner. So that is the proposed pathogenesis, and usual treatment is the wide surgical excision is enough, and of course sometimes topical retinoic acid formulations can be beneficial. Thank you.